Good afternoon. Welcome, everyone. We are just going to give it another minute as folks trickle in. I know it's the lunch hour for some, so we'll get started in just a moment. Great, thank you. So in the interest of time, let's go ahead and kick this off and get started. So thank you everyone for joining us. We are very excited to have you join us today as we unroll our Social Health Connect. I'm Siobhan Katari. I'm the Director of Health Services for Sacramento County. I also wanted to introduce, for those of you who don't know, Janine Spotnitz, and she is our Health Program Manager here, who is overseeing both our Social Health Information Exchange project as well as our CalAIM projects here for the Department of Health Services. And I will introduce some others along the way. Just wanted to let you know that we're going to go ahead and record this session today. And that way, for folks who couldn't make it, they'll be able to watch it later. So I think you'll be receiving a little icon in a second, just letting you know that we're going to start recording. And so if you can advance to the next slide, that would be great. So like I said, we're glad to have you all here today so that for those of you who haven't heard about our Social Health Connect, this might be the first time, but I know we've been talking about this for a while. And our hope is to really introduce you at a high level to our plans for moving forward to ensure that we're going to also save some time for questions and answers at the end. Just to go over the agenda very high level, I'm going to do some context setting for how we got here, introduce our consulting team from CHW who will actually go into some more details, and then we're going to give you some timelines about the planning process ahead. So to start, I want to turn it over to Janine for just a moment, and she's going to have a couple of polling questions for you so that we can get a sense who is in our virtual room with us today. So Janine.
Great, thank you, Siobhan. So as Siobhan just noted, we have two questions for you that should have just popped up on your screen as the poll. The first is, what type of organization do you represent? And you can just select as many of the options as apply to you. And then the second question is, how familiar are you with the Social Health Connect project? And I'm seeing a lot of responses come in. We'll give folks about a minute to finish responding. And I'll also note, if your organization is not listed in the multiple choice options here, then please go ahead and just enter it in the chat. Thank you. Okay, it looks like we have most people who've responded. I'll give folks a few more seconds before closing the poll. Okay, great. Now let's take a look at who is in the room here. So you should see the results on your screen here. It looks like we have good representation across different types of organizations here. And it looks like we have a pretty even split among folks who are hearing about the Social Health Connect for the first time today, and for those who've heard a bit about it before but don't know much yet. So we look forward to sharing more information, and I'll pass it back to Siobhan.
Great, thank you, Janine. So can you advance to the next slide? When Sacramento County residents interact across multiple systems, including hospitals, primary care, mental health, substance use treatment, social services, housing homeless providers, and the criminal justice system, there's currently no unifying infrastructure that links these systems or allows them to communicate with one another. And this often results in poor outcomes and to patients or clients or consumers or beneficiaries. And I'm going to use these words interchangeably for the purpose of this presentation. And what this results in, though, is oftentimes folks will fall through the cracks. This limits providers' ability to deliver the best care possible and results in less coordination and poorer outcomes for those that we serve. Often providers, including the county, have a limited view of residents' needs, challenges they experience, and resources that may be available to support them. Implementing a social health information exchange that we are calling Social Health Connect would enable quicker access to reliable and curated information on health, housing, and social service history, thereby improving the quality and efficiency of treatment decisions, facilitating referrals and communication across organizations, and reducing the risk of duplicative or conflicting treatment, coordination, or prescribing decisions. It would also allow for a deeper understanding of how patients interact across various county systems and programs. This responds to requests from providers and allows us all, the county, health plans, and providers, to implement a more robust services and care coordination under both existing and emerging county initiatives, including CalAIM and including homeless services. Our work will draw off of the experience of other counties who have stood up similar data systems and infrastructure, as well as the state's encouragement for communities to share data across sector lines to provide more coordinated care for those that we serve. Data sharing and permissions would be informed by relevant regulations and determined in collaboration with our partners. Next slide. So here's a case example adapted from the California Health and Human Services Agency that illustrates the potential impact of a social health connect. For example, an individual, we'll call him John, has both a mental health condition and a chronic health condition. In addition to housing instability, which can trigger acute mental health episodes and make it challenging for John to manage his diabetes care. He's admitted to a mental health facility for an episode of schizophrenia. Next slide. Without Social Health Connect, the mental health provider is unaware of John's medical needs and his work, the work that he and his primary care provider have done to help him manage it. If the two providers had connected, they could have coordinated their care to support John in both of his mental health and medical needs to build on prior progress. That provider is also unaware of the housing services that could be available to John, or even that a housing support provider has been trying to find him with a potential housing resource that could have a positive impact on both his mental health and medical needs. Next slide, please. With Social Health Connect, the mental health and primary care providers can coordinate care in a more comprehensive manner that better meets John's needs. With appropriate consent, they can also connect with the housing provider who has been working with John to explore the housing services that are available to him. The three sectors are enabled to meet John's complex needs, equipped with the care history and care team information needed to work together and get out of their individual silos. Janine is going to ask another polling question so that we can get a better sense of gaps within our organizations.
Thank you, Siobhan. So now we have our second polling question, and we'd like to hear from you about the types of data gaps that your staff in your organization, if you have an organization to which this is relevant, experience most acutely. So in other words, which types of data would help your staff and your organization work more effectively and successfully? And if there's another type of data that would help your staff work more effectively, feel free to select the other and put it in the chat. Great, we have about half of participants responding so far. I'll give about half a minute more for everyone to answer. Okay, great. I think we've heard from most everyone who's going to respond. So I'm going to end the poll now and I will share our results. So we can see here, it looks like there is strong desire to access data across all of these different types. At least a third of respondents selected each of these with, we can see housing status and services requested the most at about 62% of those who responded. Thank you all for your input. Pass it back to Siobhan now.
Great, thank you. And if you can advance to the next slide. So I wanted to reintroduce a few people's roles and introduce our consulting team. So Janine Spotnitz, as I mentioned, is our health program manager, and she'll be overseeing the program side of our development of the Social Health Connect. And Reddy Gurram, who I'll ask to put his hand up here, is our IT division chief over health and social service departments for the county. And he and Janine together will be the county team overseeing this. And then I wanted to let you know we have engaged CHW as a consultant team to support the planning of this effort. They bring technical and programmatic strategy and implementation expertise to this kind of work. They've most recently planned and stood up similar social health information exchanges in Alameda County. I'm going to turn it over to, and as I call your name, go ahead and raise your hand so folks know who you are. Christy, Cheryl, Rajib, Bridget, and Jennifer to take it from here. Thanks.
Great. Thanks so much, Siobhan. So glad to be here with all of you. I'm Jennifer Martinez here with Wellwork Partners, and really delighted to be a part of the consulting team that will be in support of developing this really critical infrastructure to support cross-sector coordinated care. So we can go to the next slide. I just want to reiterate one piece of what Siobhan just mentioned, that this kind of cross-sector data exchange is truly the direction that the state is going, as well as many local jurisdictions. The Sacramento County is not alone in this. There will be unique challenges and nuances to navigate for this particular community, as there is with any community that's doing this kind of work. But there is such incredible momentum at the state level that can be drawn on, as well as lessons learned from other counties that have done similar work. So building on that case example that Siobhan presented coming from the state, this is also the state's vision for a data exchange. really paving the way for this kind of effort in Sacramento County to exchange not just clinical, but cross-sector information to support more effective and equitable delivery of services. So in addition to this vision, we can go to the next slide. That's also paired with the state's guiding principles for data exchange. We are really closely tracking the state level process to develop what they're calling a data exchange framework. And we'll be working with the county to make sure that we're really tightly aligning Social Health Connect with these types of values. I'm not going to talk about each one of these that the state has designed, but specifically wanted to highlight and focus on a couple of them here. One is around advancing health equity as a kind of purpose for doing this kind of cross-sector data sharing. Privacy and security, which will be a really core tenet in how this system is designed and structured. And transparency on the terms and conditions for collecting and exchanging and using this kind of data. These principles in particular, we know are going to be particularly critical in building and protecting trust with many stakeholders like you, providers like many of you that will be involved in this work, and as well as the consumers that we're all collectively serving. So I encourage you to take a look further at the state's principles around data exchange if you're interested. Janine has a link to more information from the state level that she can drop in the chat if you want to look into it further. This is all work happening at the state level. I also do want to flag too that there's also movement, of course, around this kind of data sharing at the federal level as well. Often referred to as TEFCA, the Trusted Exchange Framework and Common Agreement, and we'll be tracking that work as well to make sure that Social Health Connect really fits the particular nuances of what's needed in this community in this broader environment. So we can go to the next slide. So wanting to move into this particular project, there's 4 big picture areas that we'll be focusing on that we're going to walk you through today. Let's go to the next. First and foremost, we are going to be working to really refine both the county and community data needs and priorities for this kind of system. We know that there are so many moving pieces in the health and social care delivery system. And that's the case always, but maybe particularly now with the implementation of CalAIM. So this is going to be a significant part of the research and investigation that we'll be doing to ensure that the Social Health Connect is really supports the specific data exchange needs for this community, aligning with but not duplicating those other kinds of investment efforts. We understand from a recent CalAIM roundtable meeting that some 81% of folks were looking for support for cross-sector information exchange and connecting some of our existing siloed systems. I think we saw that in the poll. We just saw too the breadth of additional data access that people need to do more effective care. So we are connecting these kinds of dots, knowing there's many conversations happening to ensure that there's the greatest value possible to the county and to this community out of Social Health Connect for this particular and unique chapter of policy and service change. So that will be kind of the research and planning part. We'll be talking a little bit more about that in a bit. And then the county will be carrying out a request for proposal, an RFP for a technical vendor and maybe any other additional services that they might need. Then there will be the build out itself of that system, followed by what is always a very long tail of tweaks and improvements and adjustments to the system, both to refine it and to adjust to changes and additional needs that might not be known now, but might be needed in the months and years to come. So those phases, we can move to the next slide, both the refining those priorities, the RFP itself, and then the implementation or the build out, that is a heavy lift. I would say that in general, the implementation, that build out part will take probably about 3 years for a fully implemented system. Again, there will be ongoing refinements and additional components that might be built on later on, but it'll take about 3 years to really build out that solid system, give or take. There's of course always surprises and exceptions that might come to be, but from our experience, that I think is a good estimate. So just in terms of kind of setting expectations of how quickly this will be coming through. We can go to the next slide. If we think about that then in terms of timeline, we are in a planning phase right now that I'll be talking about a bit more in detail in a moment. Then that RFP process would be taking the county through early 2023, and then there's that roughly 3-year build out phase. All throughout that, there will be planning and conversations and development work around the financial sustainability of this kind of system. We can move on to the next slide. In all of that, I just want to reiterate in this particular meeting today, the critical nature of cross-sector partnership from many individuals like you all to make this kind of system work. We are going to need partnership and engagement on a number of things. Initially, your input and feedback really throughout the planning phase that I'll be talking about in more detail shortly. And then there will inevitably be some form of a data governance structure for this kind of system. Those details haven't been sorted out, that hasn't been designed yet, but we'll likely need the engagement of a number of you. And then for you to help us connect, help the county connect with the data systems, the data feeds in particular, to flow into the system to allow for a cross-sector understanding of populations and consumers. That's kind of the technical side of it. But then I really want to flag here too that the partnership will also be commitment to using this kind of system, both at a population level and for consumer level work. The technical connections are critical, important, of course, to make for a thing here for us to make use of, but the programmatic uptake of the tool is really critical as well. A system like this in and of itself doesn't do the care coordination, right? But is a really important tool to equip consumer-facing providers as well as program and policy planners with the data that they need to engage the needs of the communities that they serve with a real comprehensive understanding of their needs. So that's kind of some of the long view, big picture. Looking ahead, let me zoom in here a little bit on that first phase of that arc around the research and planning. Again, we know that we are not starting from scratch here, and that there's already been significant investment in technology platforms and other kinds of investments from many of your organizations and departments. And we'll be working to really better understand some of the nuances around those investments, what those products do and don't do, what is working well and what's not working so well, so that Social Health Connect can be set up to integrate well with those systems and not to duplicate. So that might include, yes, data platforms, the actual technology, as well as data sharing agreements. And again, a little bit more detail in the kinds of data gaps that you all are experiencing, the kinds of critical information that you need. Again, we'll be connecting the dots both for CalAIM implementation and then also the state's data exchange framework to really poise the system to connect with those and other efforts to fill the gaps, but make sure that it's not a replication. So that's some of the research and landscape understanding for prioritization that we'll be supporting, but then also refining outcomes of what we want this kind of system to accomplish. The first, in terms of process, things like the number of data feeds that are connected, initial functionality that will be played out, which is important, but then also the use and uptake of the system, as well as impact on consumers and populations. But again, the data feed and the tool itself won't have an impact on those consumers unless, as a community, we really all commit to using it in day-to-day work. So that kind of using it component is really that bridge between the system build out and the impact on consumers and providers. So we'll be looking to define outcome measures in all three of those categories to support the implementation. Then once that research and the outcomes are defined, we'll be supporting the county to specify the specific data architecture and functional requirements of this kind of system. And again, this will be in particular attention to all the planning and implementation that's occurring across so many components of CalAIM, so that we can be sure to consider where the Social Health Connect can align with CalAIM deliverables. And we'll certainly be doing that in close partnership with the health plans and Transform Health consultants. So then lastly, will be sort of a high level build out plan, what those expectations will be of a successful bidder for the RFP, and then preparing for the RFP itself. So then that's just a quick kind of detailed look at this initial planning phase that we are engaging in with the county. I want to zoom back out now for kind of a last big picture phase, look at some of the work ahead. And for that, I'm going to turn it back to Siobhan.
Great, thank you, Jennifer. So some of you may know the Board of Supervisors for Sacramento County has already committed $10 million from the ARPA funding to support the design and beginning implementation of this project. However, we will need partnership to attain ongoing, sustainable, and permanent funding structures. Potential funding sources that will be explored amongst others include CalAIM Incentive Payment Program dollars, PATH dollars, school-based health SB HIP dollars, which is the school-based health incentive dollars, health plan investment, other health plan investments, state or local grants, and other partner investments. We anticipate that this effort will require us to braid funding from a number of sources. So we're looking for your ideas and your partnership, as this is a system that needs to be supported for our county well into the future. So with that, I will turn it back to next steps. Oh, that's me, next slide, I mean. So like we said, we need your feedback. So we're gonna ask that you respond to a survey that we're gonna be sending out to you, and we'll get your email from the registration that you completed. And this survey will be a basis for our CHW team to begin to design all of the things that Jennifer just spoke about, and also so that we can reach out to you for some additional feedback. Some interviews will be scheduled so that they can better assess the needs of our specific county and how we move forward, so we can swiftly move through the process and be informed by our cross-sector community of care. And now I will turn it back over to Bridget.
Yeah, so if folks would like to put any questions they have in the chat, we'll start grouping those together if they're similar topics, and we can triage it to the right person. And I'll just give folks a minute to get those questions in the chat.
Okay, and I received a question. Is the target patient for this system only for patients on Medi-Cal or for all patients in the state? And that's a great question. Siobhan, would you like to respond for the county's intentions for this?
Sure, absolutely. You know, as we work through building out the functionality, as Jennifer was referring to, that's where we need to be informed by this group. We really see Social Health Connect as being a larger system that's going to allow us to get a good sense of the health of our entire population. Now, that being said, there might be certain segments of the population that we start with or that we focus on first based on where the needs are. So for instance, a good example was CalAIM that was brought up, which is that's our Medi-Cal population, where we are going through some pretty immense transformations in terms of service delivery, and one of our priority populations that we will be focusing on. We may start there, for instance, or justice-involved populations or school-based populations. So that's where we're really going to be working with you all to define what are the priorities, what are the needs, and where do we start. But eventually, the hope is that a Social Health Connect can help us measure the health of our community at large. So I would ask anyone else on our team to expand on that if you'd like to.
Okay, that was a pretty comprehensive response, and I think you started to address the next question, which is what agencies from the criminal justice space were planned to be integrated?
Yeah, do you want me to take that or? So once again, I think I'll start and then others can jump in. As I definitely think we will need some planning in this space to define who needs to be involved. We already know that our law enforcement partners, our criminal justice system partners, and our health and social service partners all are working together collaboratively for certain populations. So I imagine we will be really pulling in folks from all of our criminal justice partners, whether it be probation, the DA, public defenders, the jails, but all of those folks are going to be important to really getting a good handle on how folks flow through the system, the services they receive, and the outcomes as a result of that.
Thank you. And our next question asks whether hospital ER staff and social workers will have access. And I can speak broadly to that yes, the intent is, as Siobhan described, that partners across systems, including health systems, that would include hospital providers, ER staff, and social workers. That is the intent. And as we go through this planning process, we will hear more about each sector's needs and determine which we will prioritize to include in the SHE and at what phases. So more to come on that. Then our next question is, what is the capability to integrate with other systems like HMIS and provider documentation systems, such as CRMs? Christy or Jennifer, would one of you like to take that?
Sure, I'll take that one if Jennifer can add anything. So certainly that is intended to be one of the primary focus in the planning and the RFP response. HMIS and provider documentation systems typically don't have standards for integration. So our experience is they are difficult integrations, but they are achievable. And the intent would be that we would intend to integrate and put that in the plan.
And the only thing I would add there is just that all kinds of data integrations really require both a technical connection and some program support as well to make sure that it's really clear the nuances of the different data elements. That might be particularly the case with some of the non-standard data sources. To really make sure that across sectors, we understand both how to match individual clients, but also how to interpret the data that's received. So again, quite doable, just it's challenging and needs support on both the technical and program side.
Thank you. Now we have a request for information specifically about Alameda County's SHE. And the question is whether Alameda County's SHE includes the EMS providers using the system at the field level of caring for patients through 911 calls. And if it's interfaced with EMS data vendor providers. See, Bridget, is that something you're able to respond to?
Yeah, so the SHE does receive EMS data in Alameda County, and there are specialty EMS providers that use the CHR interface in the field. There are some behavioral health response teams that run through our EMS system, and they are actively using the tool through the 911 response system on the scene when they're with clients.
And I will add to that, Bridget, that in addition, Alameda has actually been interfaced to 2 EMS vendors. The original vendor, when we first launched the project in Alameda, and as they changed vendors midstream, and are now integrated with ESO. So yes, there is a full integration there.
Great, thank you. Now, question for education data. Are there plans to integrate education data and or data from school health services? Siobhan, would you like to respond to that?
Yeah, no, for sure. We have been in discussions with SCOE already, and SCOE is showing a great level of interest in doing this. And so some of our discussions around the SP HIP strategies and funding with our plan partners have been to look at supporting the Social Health Connect with those dollars, and that we definitely intend to integrate school-based data. Now, once again, I'll go back to what we've been talking about is we need to make some determinations about timing of rolling these different sectors in, and also about what data can and can't be shared. And that's all through our data sharing agreements that we'll be working on here over the next year. So I appreciate the question.
Thank you. Now we have a question about statewide HIE. Could a statewide HIE link EMRs, databases, and socially oriented databases to be combined into one repository? And also, would school-based data sources be linked in as well to ultimately create social determinants of health scorecards for each member? Jennifer, is that something you're able to speak to? I know it's asking about the state's plans rather than necessarily our plans as a county.
Yeah, I'll answer that in two ways. The state's data exchange framework actually is really specific that it is technology agnostic. So it is not in and of itself creating a state level repository that this kind of system could draw on. That said, there are many potential data sources that could be useful for this implementation that could be bigger than just Sacramento County that the county could decide to connect to. Sometimes there's some efficiencies in connecting with some of those bigger structures that can cover what would have otherwise been a number of connections. But when it's bigger, sometimes there's less ability to be flexible to make sure that it's really meeting the particular data exchange needs of this community. So I would say that that's something that will certainly help the county weigh, and there's pros and cons to both, connecting to some of those bigger networks or not. And where it's productive, that would be prioritized. So more to come on that.
Now we have a question about security. How will role-based security be applied for HIPAA covered data from non-HIPAA entities? And similarly, another question, how much control over release of information will the patient have? Cheryl, can you respond to that?
Sure, thanks, Janine. So certainly the development for security is to be determined, but in general, access to a community health record is protected with a couple of layers. So certainly role-based security would be one component, which may make sense to differentiate between a covered entity and a non-covered entity. Another layer that comes into play is the release of information, and that actually is kind of a segue to the next question, which is how much control would a patient have over that release of information, so if you all proceed and have all of the stakeholders help to develop the release of information, that will be in your hands. But I will say, generally from our experience, the most effective release of information do not allow the patient to do a lot of cherry picking in and out of the types of information they wish to share. However, I think there is also experience that shows that the length of that release would likely go for about a 1-year period. A lot of organizations are doing that. So they could commit, and then either the authorization could be revoked, or it would expire by the defined amount of time.
That's helpful. Thanks, Cheryl. There's one other question related to that. I'm just going to group on there. Will there be a universal ROI model used throughout the state, and who would provide this? That's something, Jennifer?
Maybe I can build on what Cheryl was just talking about. Through the state's data exchange framework, work, there is certainly consistent ask for at least a model consent that could be modified and used throughout the state. And there hasn't been a no, but it hasn't been a really clear yes yet. There's been so much thinking and work around kind of best practices for this kind of consent that I would really hope that the state would make a good version and make it available to implementations like this. So if such a release of information becomes available, it's certainly something that we'd look at. Our experience in other counties too, though, I will say that even when there is a good model, then to really cater to the specific needs and landscape of providers and connections and how that is all architected often requires a pretty unique release of information that accurately reflects a consumer's choices and who would get access to what type of information. So I might anticipate that ultimately there would be a Sacramento County specific consent that would fit in here, but I would love to be surprised if the state provides one that covers enough of the bases and feels comfortable for this group of stakeholders. Cheryl, anything else I missed there that you want to add? No, okay.
Thank you. Now we have a question specific about psychiatric hospitals, and will the private psychiatric hospitals be looped in at a more detailed level than can be obtained through access tracking? Also, will crisis residential programs be looped in if possible, given IT constraints? So broadly, I would say those are great questions and something that we will explore through this planning phase. And I'll see if our consultants, Bridget, do you have anything to add from Alameda County's experience?
Yeah, there are crisis residentials in Alameda County that do have access to their community health record, primarily the ones that have most of the Alameda County behavioral health individuals who are placed by the county into those crisis residentials. And so they have access through behavioral health to the system. So it's primarily, all that to say, it's primarily people on Medi-Cal that they're seeing in their system. But they do have access, not all of them, they've opted into it if they wanted it. And that's been working really well to give them context beyond just what they might see in the behavioral health record.
Thank you.
I'll also maybe add, Janine, that for several of these questions about the different programs, I just wanted to really encourage folks as we send those surveys out to really get us your ideas and your information. And certainly, as we referred to earlier, we will be putting together teams and governance structures and all of those things where we can make some collaborative decisions about what we prioritize and what we phase in and what's possible and what's not based on data sharing agreements. But I would say, please put those thoughts and ideas in surveys. So we don't have answers to everything today, but it's where we're early days. So we are exploring what's possible here as well. Thanks.
Thanks, Siobhan. I think that response applies to other program-specific questions, including the question around whether we're envisioning the ability to track and connect to prevention services, such as home visiting and parent education programs at Birth and Beyond. So appreciate the question, and we'll look forward to all of your input through the survey, as Siobhan described. Okay, and then I see a broad question about outreach, and that is, what kind of outreach is being considered so that we are able to reach our diverse community in Sacramento, such as insured, uninsured, et cetera? And how is this plan also ensuring language equitable access and providing cultural competency? So for that, I think, let's see, Siobhan, do you have any initial thoughts in responding to that?
Yeah, I'll start out, and certainly, once again, our consultants are going to help us with developing our plan for outreach. But I'll just start out by saying we recognize Sacramento County as a very diverse community with multiple stakeholders that we need to hear everyone's voices. Our Board of Supervisors is very committed to ensuring that we outreach to communities to make sure that we're listening and pulling in all the information necessary to make culturally and linguistically competent systems and strategies. And so absolutely we'll be doing that. I don't have the specifics right now as we're still in the planning phase, and I would ask my plan partners if there was anything from your experiences with other counties that you could lift up as potential strategies for this.
Also,
Sorry,
so
Jennifer,
please
do you
do
like
feel free to
that?
weigh in on the chat, participants, and I'll ask our consultants if they have any relevant experience from Alameda County to share.
A couple of pieces I will jump in and share. From Alameda throughout the implementation of a social health information exchange and a community health record, we did bring together a really diverse set of providers from different sectors and from leadership to line staff to really help refine and kind of gut check the needs on the ground to make sure that this was a data system, not for a data system's sake, but was really meeting the tactical needs, both on the ground for client-facing work as well as program planning that might be more at a population level. So, sometimes that can be an ongoing gathering of that breadth of providers to make sure that there's ongoing feedback, or kind of a tactical team that can be brought together when there's specific parts of the implementation that need that kind of intensive feedback. In Alameda County too, we also were blessed to have a group of what we call consumer fellows that were a group of consumers from different parts of the system that were receiving services across the system of care that gave a lot of really critical feedback for both how data was exchanged, but also how the consent was read as improvements were made to that tool to make sure that it wasn't just consultants that were making those changes, but made sure that the information was being shared really carefully. That was a group that needed a lot of support, so I cannot commit that that would be a tool to be made available in Sacramento County, but making sure that there was broad consumer input in the development at certain key pieces made a big difference in Alameda County. So things like that, and that can be intensive or a lighter touch depending on what's possible in the implementation. So those kinds of lessons learned we'll certainly be weaving into the conversations here.
That's helpful. Thank you, Jennifer. Now we have a question about tracking people when they move between counties. How easy do you anticipate it will be to track people when they move between counties and access their record from the other counties? Christy, is that something you're able to speak to?
Sure. How easy is it? Well, that's a good question. It isn't very easy, but that's certainly, there are certain components that we can look at. Certainly from the clinical side, tracking utilization across counties, that's easier to do than some things like access to housing, which is usually specific to an individual county. But it is a consideration that we'll look at, but it is certainly a challenge.
Thanks, Christy. I see a follow-up question from a previous response. ESO was mentioned earlier in the call. Is that the selected platform vendor for the Alameda SHE, or is that just the platform for EMS referrals that then integrates into a larger platform? Christy or Rajiv, can you speak to that?
I'll take the first part of that, and Rajiv can answer. I throw out an acronym and I didn't say what it supported. ESO is actually the first responder system. They use that system to collect data when they engage with the patient. And then that system also connects with usually local hospitals. And so that system is the system that is integrated with the Alameda platform that holds the SHE.
Yeah, I think you covered that, Christy. Yeah, so ESO is basically what we call ESO is a electronic PCR system that EMTs use to record when they transport a client, a patient, after they receive a 911 dispatch. Once that transaction happens, that a person is person details entered into their system, ESO system, we get a real-time notification to the Social Health Information Exchange within Alameda County about that event.
Thanks, Rajiv.
Thank you, Rajiv and Christy. And I see just a follow-up to that. Who was the vendor for the Alameda sheet?
It's a company called Up Health.
Thanks. Now we have a question about who will decide which organizations at the community level will be able to access the system. And more specifically, what criteria will be used to determine which organizations are included? And then will resource poor but culturally important programs be offered assistance in engaging and equipping their organization to participate? Siobhan, would you be able to respond to that?
Yeah, I think I'll start out with the last part first, which is we recognize we have a lot of organizations in our community that are resource poor, would not have the equipment necessary or the software necessary potentially to make a huge investment, but are critically important in the lives of the folks that we serve. And so this system is not intended to be proprietary only for those organizations that have resources. It's really intended to be for those organizations that are providing services to our community. Once again, we're going to have to figure out, with all of the moving parts and all of the organizations and all of the data sharing agreements, how to tie that all together. But I'll just start with the intent that we don't leave folks out of that discussion for sure. I will see if our consultants have any thoughts from your previous work about how maybe smaller organizations have participated in this process.
I can jump in there. I will say part of the prioritization process, I think too, is helping to clarify, what are the specific use cases for using this kind of system. I don't mean to be a broken record here, but it's really easy to feel like this data system will get stood up and it will solve all our problems. But it's really about how that data system is used for what kinds of functions by what types of individuals. And it does need that technical piece, but also program support to help to sort out where exactly does this interact with a workflow? What action would that trigger for, say, a care manager in the field or someone working with a CBO? So I think there's also some of the planning work will be, what are those workflows that we really want to focus on for support around this kind of system? And again, as Siobhan said, how does that align with all the other moving parts, whether it's CalAIM or otherwise? And that also might help to prioritize which organizations would make the most sense for them to onboard or participate in this kind of system, so that there's the right support for them at the right time to engage. So it's all a part of the discovery process we'll be supporting.
Great, thank you, Jennifer. And thank you again to everyone for all of your thoughtful questions. It seems that we've gotten through all the questions we received right on time. So that worked out well. I will encourage everyone, if you have any questions after this meeting, feel free to reach out to me. My email is on the screen here. And I want to thank everyone for participating today. And I'll pass it off, Siobhan, if you have any final words.
Great. I'll just, echo what we've been talking about throughout this hour, which is really about, the Social Health Connect is really about our partnership and our ability to work together. And I think Brian Jensen, who's on the phone, said it to me when I arrived here, is that a social health information exchange is more of a verb than it is a noun. So we've got a product that we've got to get to. but it's going to be all of the work we do together, all of the work around how we share data, how we coordinate care for those that we serve. That's going to be the important part of this project that's going to get us across the finish line. So once again, in advance, thank you for your input, your partnership, and we will look forward to many more conversations in this space moving forward with you and your teams, and appreciate everyone's time today. Thank you.